Good morning. You might have guessed by now that a study of this size is never short on an opportunity to create some crazy graphs. And we're about halfway through, so I hope you'll bear with me. So far, Steve has really provided a lot of the background information that describes what is out there in terms of what communities are doing to address childhood obesity. And I have just one more element of describing what is out there before we switch to thinking about what is the impact of that. So this graph that you see here describes the prevalence of the 9,681 CPPs that were documented through this study by sector. And you can see they're really concentrated in the school setting. And while we think that this is likely true, and I should say that's then followed by youth-serving organizations and parks and recreation departments, while we think this is likely a valid observation, it could be influenced by the fact that about 25% of the 1,421 key informants that were interviewed as part of this study to identify community programs and policies were from schools. It could be influenced by that. It's also worth noting that we documented community programs and policies that really fell across all levels of the socio-ecological model. Examples included things like individual level counseling for children at particular risk of developing childhood obesity. At the individual level, at the interpersonal level, we did document instances of the family-based therapy work that's occurring across different communities. At the organizational level, these community programs and policies, or CPPs, included things like school organization changes like removal of vending machines. At the community level, we documented instances of new trails, new farmers markets that have an influence on access to opportunities to engage in physical activity or healthy eating. And then lastly, a number of policies were documented, such as complete streets. Our takeaways from this include that most communities implemented community programs and policies through schools and had an average of 7 sectors that they were working in to do their work. We did note that some of the effects that we'll talk about next in terms of having changes in obesity interacted with distribution across multiple sectors and intensity. That is, higher intensity efforts distributed across more sectors had more benefit for childhood BMI. So it really is important as we look forward to think about how do we continue to engage across diverse, multiple sectors and across the socio-ecological model. In terms of overall results, I think that Steve presented a little bit of this. This shows you the standardized intensity of community programs and policies rolled up across each of the 130 communities. And it's standardized in that the very lowest level of intensity is occurring at 0, and the highest level is occurring at 1. And what we determined was that over time, the overall intensity of efforts increased significantly from beginning to end of our study. This graph is one of the key findings of the study, and it shows the relationship between community program and policy intensity score and a change in childhood BMI for each of the 130 communities, which is why there are 130 different lines on this graph. Again, no shortage of opportunities for crazy graphs. The black line that you see through the middle is the mean change over time. And what we determined was that between the lowest intensity and the highest intensity, there was an improvement in childhood obesity of 1.4 units. So that is, when you compared the highest to the lowest, they were different by 1.4 units. And for communities that had the average level of an intensity, the difference between the average and the highest level of intensity, it was a difference of 1 BMI unit. So we did conclude that intensity of community programs and policies is significantly associated with lower BMI in children. And for a community that goes, again, from that sort of minimum intensity level to a maximum, there's a reduction of 1.4 BMI units. And it really reflects that community investment matters in assuring conditions for healthier weight among children. So in this study, we collected enormous amounts of data that could also help us better understand the conditions under which these effects were observed. So we looked at modifiers that occurred at the child level, the family level, and the community level. And I'll start by describing some of those effect modifiers at the child level. They essentially what this table tells you is that there are some children that experienced more benefit from community programs and policies in their communities. These tended to include children who are male, children who are white and non-Hispanic, and their overall family income was higher than $50,000 per year. Additionally, we observed that children who had parents with higher education and who had full-time employment also had more benefit from the community programs and policies that were occurring in their communities. So this really suggests to us that children and family factors are important and do influence the impact that community programs and policies have on BMI, and that there are specific children who are more benefited from those community programs and policies. So it may require that assuring conditions for a healthier weight among all children may need more intensive and targeted community investment. We also looked at community-level modifiers for BMI and CPP relationships, and we found some similarities with the child-level factors in that predominantly white, non-Hispanic communities experienced more benefit, and the significant findings that we had overall were not observed in communities that were predominantly African American or predominantly Latino. This graph shows you a little bit more about that relationship. Here you see, again, a scatter plot of all communities distributed by whether or not they had a primarily African American population, primarily Latino population, or the blue line reflects primarily white population. So in this, you see that the relationship between CPPs that were implemented in the community and child BMI is more significant for those communities that were predominantly white and was not significant for those communities that were predominantly African American or Latino. To us, this really suggests what I think many of us in this room already are talking about on a daily basis, that place really does matter in the work that you're doing, and that it's really important to focus on conditions in those places and consider how we assure that they are health promoting. In terms of overall takeaway messages from this huge study, we do think that planning, implementation, and evaluation of obesity efforts would benefit from systematic measurement of the intended or actual dose of interventions. When we think about overall dose of what matters, it's clear from this study that in order to be sufficient to improve BMI outcomes, one must consider the total intensity, that is the amount and kind of CPPs that are implemented within communities. We need to consider how we target multiple behavioral objectives so that we're not focusing only on fruit and vegetable intake, but we're also accompanying that with a comprehensive effort that maybe includes decreases in sugar-sweetened beverages, so rather than a siloed effect across all behaviors. Penetration through multiple sectors is important. Again, we did find that the effects of intensity were amplified when they were distributed across multiple sectors in the community, and that time really matters. So in our study, we looked at the length of time of individual CPPs and found that the longer they were in place, the more improved outcomes we observed. But also that there's a little bit of a lag between when you begin and start your implementation and when you see impacts. And ultimately that lag was anywhere between 18 months to 24 years. So when we're all sort of under the pressure to show outcomes in just a few months or a few years, it's really hard to do, particularly when you think about lag and the opportunity to see your work flourish. And then lastly, really informed by some of this information that we found, that there was differential impact for children who were living in predominantly African American and Latino communities. It really means that equity and justice really require us to assure that more intense and targeted doses with populations and places experiencing health inequity is really important if we do hope to achieve change in BMI for all children. Before I wrap up, I did want to feature just a few of the examples of the work that our center at KU is doing to help understand community-level interventions to enhance health equity and address risk for chronic disease. Over the next few minutes, I'll feature a few projects that we are working on. Foremost among these is our partnership with the Latino Health for All Coalition in Kansas City, Kansas. This coalition was established in 2008 in response to a number of known factors that suggested inequity was being experienced by Latinos, and this really included low consumption of fruits and vegetables, low engagement in physical activity, limited access to health services, and sort of a concentration of poverty and low educational attainment in predominantly Latino communities. Our comprehensive community initiative has been working over the last 10 years to address conditions in which health occurs, and I'd like to highlight some of that today. Again, with the socio-ecological model, I wanted to tie in that the coalition really focuses on the organization and community levels of this work and is focused on creating conditions in which health occurs. Since 2014, when we received a Centers for Disease Control Racial and Ethnic Approaches to Community Health, or REACH grant, we've been focused on implementation of the Healthy Spaces, Healthy Places model. And my colleague Monica will be talking a little bit after lunch and going more in depth with our food work around creating healthy food retail environments. But that's a cornerstone of the work, as well as creating healthy parks in which there are more opportunities to be active and increasing access to health services. As we are approaching the end of our 4-year implementation of the Healthy Spaces, Healthy Places work, we have data coming in that reflects or suggests some interesting outcomes at the both intermediate and behavioral levels. These include increased access to enhanced parks and increased access to opportunities to purchase healthy foods through the 14 restaurants that are participating in our healthy food retail work and the 10 corner stores that are participating in that work. In terms of behavioral outcomes, we're already observing significant increases in the total number of users and the level of vigorous activity at parks with enhancements compared to those without, using the SOPARK assessment. Also, we know that the purchase of healthy options at food retail sites participating in the healthy food retail environment has significantly increased compared to those that are not participating in our work. A few other examples that I'd like to highlight before closing include some of our work that's occurring through our academic health department relationship with the Lawrence Douglas County Health Department. We've had the opportunity over the last several years to support the evaluation of their safe routes to school work that is really focused on better understanding the different doses that are occurring at schools, to understand how the different E's are being implemented, and not only understand its impact on walking to and from school, but also driver behavior around schools. We're also the backbone support for the planning that's going on regarding healthy food and physical activity as part of their comprehensive community health improvement plan. And lastly, I'll mention that we're the lead evaluators for the Healthy Schools, Healthy Communities initiative that's funded by the Missouri Foundation for Health. That initiative is occurring in 33 school districts across Missouri that are distributed across 13 counties. And as we come to the end of our first cohort, we have a lot of promising data that suggests that several communities have been successful in reducing the level of childhood obesity in their communities. With that, I'll stop, and I think we have time for questions.